Hi, everyone. So I'm thrilled to have for us to have Dr. Popp with us today. Dr. Popp will be talking about everything you wanted to know about supportive oncology and palliative care, but were afraid to ask. Dr. Popp is Associate Professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. She trained in medical oncology and palliative care and has spent over 20 years in practice dedicated to improving pain and symptoms and providing support to patients experiencing cancer at all stages. She's a graduate of Indiana University of Medicine and did her internship, internal medicine residency, and medical oncology fellowship at Indiana University Medical Center in Indianapolis. She did a cancer pain management and palliative care fellowship at Memorial Sloan Kettering Cancer Center and has worked in oncology and palliative care, developing inpatient and outpatient programs in several hospitals in the New York area, including St. Vincent's Catholic Medical Center, Maimonides Medical Center in Brooklyn, the New York Harbor VA, and now Mount Sinai. So we are absolutely thrilled to have Dr. Popp with us. And personally, she lives in Brooklyn with her husband and is the mother of 4 sons, and she enjoys knitting. So thank you again, Dr. Popp, for joining us. The floor is yours.
It's my pleasure. We have to update my bio. I actually got promoted to professor since the last time I talked to this group.
Yes, I'm so using the old one. Congratulations.
It's really nice to be here with all of you. I really enjoy the opportunity to talk to patients and families about how palliative care can help them as they're coping with the uninvited guest of cancer that has appeared in their lives. I often think of it as kind of a squatter who's come into your life and you can't evict always, and you have to figure out how to live with. So with that introduction, I'm gonna see if I am able to successfully share my screen. Can you let me know if that worked?
Works.
Yeah?
Yes.
Excellent.
Thank you.
Many of you are of a vintage where you'll kind of recognize the reference to the title of my talk. And I borrowed it from David Rubin from probably 30 years ago, who had this New York Times bestseller about a topic that everybody had curiosity about, but was often nervous to speak about or to ask their questions. And I find that palliative care is similar in those regards. So here's your chance to learn about it, and we'll offer an opportunity at the end to ask questions. Of course, I'm going to ask, as you can imagine, that you not ask any specific questions about your own medical care. Those are all too individual for a setting like this, and obviously you should be speaking to your own healthcare practitioners and your cancer care team about specific questions, but I'm happy at the end to answer some more general questions about what we discussed today. So what we'll do over the 45 minutes or so that we'll be together, where I'll be doing most of the talking at the beginning, is to make sure you understand what palliative care is and who can benefit, to talk about how palliative care can really enhance the care of women who are dealing with gynecologic cancers, and resources to learn more about palliative care, and then we'll have some time at the end for questions that you may have. So the first question, of course, is what is palliative care? And palliative care is specialized medical care for people living with a serious illness. And I certainly don't have to tell any of you that cancer of any kind falls into the category of a serious illness. Palliative care focuses on relief of symptoms and the stress that comes from finding out that you've been diagnosed with a serious illness. And the goal is really to improve the quality of life for the patient and their family, however they define family. Sometimes family is our blood or biological relatives, and sometimes family are the family that we've chosen to make our family. So palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with the patient's cancer care team in this case, but if they have a serious illness that isn't cancer, it's their other doctors who are managing that illness. And the palliative care team provides an extra layer of support. Palliative care is appropriate for patients of any age and at any stage in the course of their serious illness, from the time that it's being evaluated and first being diagnosed, and throughout the trajectory of any kind of treatment that they're receiving. And I want to make clear from the outset, because it's often one of the misconceptions, is that palliative care can be provided and should be provided alongside, when it's needed, alongside with specific treatments to treat the serious illness, cancer or otherwise. I'm going to, just so that it's not so wordy, stop making the cancer or otherwise parenthetical comments. And whenever I make reference to cancer or gynecologic cancers, please realize that I'm speaking about that specific case because of the audience of a women-to-women session, but certainly this can have relevance to any serious illness, or whether it's other kinds of cancer or other serious illnesses. So what you're learning about may not necessarily be relevant right now to you with regard to your own gynecologic cancer, but may be relevant to family members that you have who have other kinds of serious health conditions. You know, when we think about palliative care with regard to cancer, I don't have to tell a group of people who have been experiencing cancer to realize that, you know, once someone hears that they have a diagnosis of cancer, you know, the things that they're hoping for are to achieve a cure when that's possible, or to keep the cancer in check if a cure is not something that we can expect to do, to make sure that they maintain good function and really maximize their quality of life, however it is that they define quality of life, because that's really something that's really very personal to all of us, depending on what our own goals and priorities and values are. It's important to make sure that you've got well-coordinated care, and that everybody who is trying to help you deal with the cancer are working in conjunction with each other and are connected to each other. And people want support to make sure that they can make informed decisions, and that those are the best decisions for the specific goals and values and priorities that they have as they're dealing with their illness. So those are all really the sort of highly important aspects of care for anyone who's been diagnosed with cancer. And how does palliative care fit into that? Well, quality of life can certainly be impacted significantly by cancer, whether it's the symptoms that the cancer causes that lead it to be diagnosed, ongoing symptoms that a cancer can cause, or side effects and symptoms that are related to treatment of the cancer. And treating the pain and the symptoms and the stress that comes with a cancer diagnosis is absolutely as important as treating the cancer itself. If we make the tumor smaller, but we don't address these other things, it can still have a very significant impact on one's day-to-day life. And early integration of palliative care along with cancer-specific or disease-directed therapies really is what results in the most improved outcomes and best quality of life for patients and their loved ones. So the key benefits of including palliative care along with disease-directed cancer care is that it focuses on the quality of life issues for the patient and their caregivers or loved ones. To keep in mind that it's appropriate at any stage and at any point in the illness where symptoms and stressors are bubbling up and interfering with day-to-day activity, and that it can be and should be provided together with other treatments that are of benefit. And palliative care team really works to help you understand and make sure that the treatment you're getting is well matched to your goals and what's important to you. It's provided by an interdisciplinary team of palliative care specialists, much in the same way that your cancer care is provided by an interdisciplinary team of specialists. You know, you have your doctor, often you have a nurse practitioner, you have nurses who are providing the treatments as well as assisting with things that happen in the office. You have a dietitian, you have a chaplain, you have sometimes an art therapist, you have your peer group support like Women to Women. They're really social workers. They're really a lot of people with different kinds of backgrounds and training who all work together to help you get through your cancer experience in the best possible way. And adding to those group of people who are part of the primary cancer care team with additional folks from palliative care can really provide an extra layer of support during times when things may be more difficult and that extra layer of support is needed. One of the things that likely will come up as we're talking is that there are often a lot of misconceptions and misunderstandings about palliative care. But once people are informed what palliative care actually is, almost everyone wants to have it for themselves or their family if they were suffering from a serious illness. And it's almost universal that people believe that patients should have access to palliative care at all hospitals. Certainly happy to say that all of the hospitals in the Mount Sinai system, really all the large hospitals in the New York City area, do have access to palliative care services for their patients during an inpatient hospitalization. A large majority of patients also agree that it's important and that patients and their families are educated about what palliative care is so that they're well informed and can access it when it's appropriate for them. The oncology folks, that's not just the palliative care folks saying, pick me, pick me. The oncology folks, and ASCO is the American Society of Clinical Oncology, which is the professional society for oncologists who treat cancer medically, so treat cancer using chemotherapy and now immunotherapy or oral medications, have updated their clinical practice guideline. Now it's about 6 years ago, saying that patients with advanced cancer, meaning cancer that isn't likely to be cured specifically with surgery itself, done once, or that's spread outside the immediate area where the cancer started, whether they're inpatients or outpatients, should have access to dedicated palliative care services, should have that access from early on in the course of their disease, and that they should be able to receive those services at the same time that they're receiving what oncologists refer to as active treatment or medical oncology treatment. And referring patients to these services is really optimal, and that they complement existing programs. And we are fortunate to work so closely hand in hand with our oncology colleagues, both at the Ruttenberg and Dubin centers uptown and down at Chelsea, where I'm based. We have palliative care services that are what we call embedded in the cancer treatment team. So we're on site, we share a medical record, we're in regular communication, and really kind of, rather than it being sort of two teams that are working together or even interlaced with each other, it really is that we become one bigger team, working together in a very integrated and seamless way. There are other models by which palliative care services function. And we also have in the Sinai system 3 what we call freestanding palliative care clinics, where we see patients in our own space. And actually in all 3 of the spaces, we share it with geriatrics, because just from an administrative organizational standpoint, our department is a combined department of geriatrics and palliative care. There are a lot of overlap in those 2 medical subspecialties, and there are it has to do in part with how palliative care developed within the Mount Sinai health system and the medical school. A lot of the real leadership in palliative care here were folks who came from a background trained in geriatrics. My own training, as you heard from Jillian, is different. I came from a background of being a medical oncologist. But in those freestanding clinics, patients are seen much the same way somebody would go to a cardiology office as part of a multi-specialty clinic, and are seen. And the doctors and nurses and other folks on the team are still in communication with the other healthcare teams that are working with the patient. They're just not necessarily co-located, and they're not able to have kind of joint visits or visits back to back in the same practice space, but they're still going to be in touch with one another and coordinating care with one another. I'm going to go from sort of the most general to now a little bit more general about cancer, and now kind of focus in even more on special challenges that are related to patients who are dealing with gynecologic cancers, and talk about some more specific ways that palliative care involvement in patients' care can be helpful. So
Dr. Popp, before, there aren't any questions in the chat, but I just wanted to check in if anyone had any questions before you move on to this.
Sure.
I mean, we can use the chat, or anyone feel free to raise your hand if you have any questions right now. Oh, Catherine, go ahead, and you're muted.
Oh, you have to unmute,
Catherine. You're muted.
Okay, I'm working outside of your system, and am I the right person that you were calling?
You know what? I was calling Catherine, but Kathy, you go ahead, and then Catherine will go.
Apologies. My name is Kathy.
No, it's
fine. I just wondered if somebody being treated at Sloan Kettering, at which I am, could also receive palliative care at Mount Sinai, if that were indicated. I was referred to you by somebody who works at Mount Sinai and knew both systems well. I was referred to these talks and to your staff.
Yeah, well, we're happy to have you join us wherever you're getting your care.
Thank you.
All of the major cancer centers in the New York City area, which certainly includes Sloan Kettering, Mount Sinai, Columbia, NYU, all have excellent palliative care programs. They're set up in varying ways. They're not all necessarily integrated. I actually trained many years ago at Sloan Kettering, and they continue to have both inpatient and outpatient palliative care available. We have in our system at Sinai have the 2 integrated sites for patients who are getting their cancer care at either Ruttenberg or Chelsea, but at the freestanding, the 3 freestanding practices, patients are seen who either have other serious illnesses that are not cancer, or are getting cancer treatment someplace other than Ruttenberg or Chelsea. So that can be other places within the Sinai system, or places that are not part of the Sinai system.
Okay, so just to clarify that last point, if I may, somebody like me should go to one of your freestanding palliative care facilities, or also Chelsea?
So somebody who's getting care outside the Mount Sinai system could either get palliative care where they're getting their cancer care, or they could come to one of our freestanding practices.
Okay, thank you. Thanks very much.
Sure. And Catherine, you had a question also?
I was just going to say, at the end of the session, will you have information about how someone could schedule an appointment?
I don't know that I have it on a slide, but if you help me remember, I'm happy to provide it verbally. Put it
Perfect. Thank you.
Sure.
That was actually my question, which was how to access palliative care, in this case within the Sinai system.
Okay, we will talk specifically about sort of raising the issue with your doctor towards the end of the talk, and I will, with Jillian's help or your help with my memory, make sure that we give specific information about accessing services.
And just to be clear, because I think a lot of times palliative care gets confused with end of life care or simply supportive care rather than treatment. We're talking about just supporting throughout one's treatment, not necessarily hospice or end of life care.
Yes, that is one of the most common areas of confusion. And I'm happy to address that a little bit now. It's something I've got a couple slides on as we go further through. But, symptoms can be, and stress of serious illness can be significant at lots of times throughout the course from diagnosis until, you know, our last day, whether our last day is related to our cancer or related to some other thing, and however long one lives with cancer or having had cancer in their past. So palliative care includes all of that. So it includes from the time of diagnosis, side effects related to treatment or cancer recurrence, if it goes away for a while and comes back. It also includes care at the end of life. Symptoms can be significant and need a lot of expert care towards the end of one's life, whatever the thing is that makes us have an end to our lives. But I think it's important to make the point, and I will try and make it several times, that it is not exclusively end-of-life care. It is all of those things. And hospice care is a specific subset of palliative care aimed at patients who are towards the end of their lives and with a few other specific twists and nuances on it. The names, yeah, the names get used differently. And some of that is kind of location specific and related to the culture of the health system where people are getting their care. There were lots and lots of misconceptions about palliative care, just as you alluded to with your question. And some places found that they spent less time and effort getting rid of misconceptions if they use the term supportive care or supportive oncology rather than palliative care. And so many major cancer institutions, Sloan Kettering, MD Anderson down in Texas, actually call their palliative care services supportive care or supportive oncology. We in the Sinai system use both terms. Our two embedded practices at Ruttenberg and Chelsea are called supportive oncology, and our three freestanding practices are called palliative care. It's both helpful and sometimes adds to some confusion. And, you know, I see patients in one of the freestanding practices and in one of the embedded practices. So it's often the same people doing the same things. It's just, what did Shakespeare say? A rose by any other name still smells as sweet. So sometimes it has to do with avoiding those misconceptions and stigma that can come from misconceptions. Any other questions, or should we move on to specifics about palliative care assistance with gynecologic cancers?
I have a question.
Sure.
So in talking about palliative care while you're in treatment, would it be similar to seeing an integrative doctor, someone who could kind of help with all the different things that the treatments cause to happen?
That's a great question. And I think that, yes, there are palliative care doctors who take an integrative approach. They may or may not have done formal training in palliative care. They may or may not have done formal training in integrative medicine. I think, you know, in that regard, palliative care is the approach of trying to alleviate symptoms and stress. And the integrative medicine folks often take an approach that uses less pharmaceuticals and often will use a lot of mind-body approaches and often try to use some herbal and natural or homeopathic approaches rather than, you know, medications that you would get from a pharmacy when medications are used. We certainly try to use a broad range of treatments, not only medications. But I think that's the way in which an integrative medicine specialist would kind of fit into this notion.
Thank you. Do you have a name?
So ovarian and uterine cancers, most commonly just the nature of the way they come to our attention, is that they often present in the later stages of disease, which means that they often present with symptoms, and the symptom burden can be high due to the cancer itself or related to some of the treatments. Not everyone recognizes the symptom burden that patients go through. Some people, and I'm happy to say I don't think it's the case with my colleagues where we're working at Chelsea, but not everyone recognizes what the experience of going through a cancer diagnosis and treatment is like, and can sometimes be a little bit too focused on the CAT scan or the PET scan and the measurement of the tumor, and not the experience of the person that tumor is living with. You have to make a lot of decisions along the way about what kinds of treatment to get. Sometimes there's several different kinds of treatments that may be reasonable options, but have differences in terms of time frame or intensity or side effects. And you have to sort of make decisions about those things together with your doctor. I'm happy to sort of gray out a little bit this last tile on the screen, which is, the last few years and the last time I spoke to women, COVID-19 was really front and center and almost more of a concern than their cancer. Happily, things are slowly but surely either going back to the old normal or finding a new normal. Today, when I walked into Chelsea for the first time in 3 years, there wasn't a table with a staff member sitting in front of it, sort of screening patients and handing them masks and stickers. And it was really nice to see that while everyone's still wearing masks here for the protection of the patients who are immune systems are weakened, it was really nice to see that area look like it used to look for the first time in 3 years. And I think we're all doing our own mental adjustments to what we've been through in the last few years, and trying to find either comfort with the old normal or comfort with a new normal, as that case will be. But for those reasons, I am kind of acknowledging that that is still something that's a concern, but not something we're really going to spend a lot of time talking about today. And I look forward to just taking that off my slide altogether, hopefully by the next time I give it. So when we kind of think about the things that are challenging for patients with gynecologic cancer, we sort of wonder, how well do we do meeting these challenges? And I think when we look back to when I, started my career, finishing my training in internal medicine and training in medical oncology, and started to get interest in the evolving field of palliative care, I would have said we don't do a very good job, and we really didn't in those days. And I'm happy to say that we've come a long way, and that's on both sides of the equation. The palliative care side of things have gotten much better at learning things. We have better and better tools available to manage symptoms. We've learned to understand the symptoms more and more. How they develop, how they evolve. Some of them we can prevent, anticipating the ones we may not be able to prevent. And our oncology colleagues have really come to appreciate the importance of our working together with patients and their families through the course of all things. So I think we're used to say, uh-oh, and now we're saying, getting better. And, there's always room for improvement, but I think in many of our healthcare systems, we do a pretty good job now meeting these challenges. And in doing so, we really help people have an improved outcome. And certainly that means better quality of life, but that also often means living longer, not just living better. Which is really one of the things that's most exciting. Is we've had some research, most of it has come from other cancers, most notably lung cancer, but we've actually had some research, and we're starting to look at it in other cancers that show that people actually live longer in addition to living better. And when you're living better, you're particularly happy to be living longer. And the palliative care team will work with the the rest of the cancer care team and with the patients to find the right medicines to control difficult symptoms or treatment side effects, make sure things are well matched, help with addressing gaps in care, particularly those gaps that can lead to unnecessary hospital stays, because most of us want to stay out of the hospital if we can have our needs met as outpatients. And also, you know, it's a life-changing event to hear that you have cancer or that someone who you love and care about has cancer. And sometimes our role is just to help people adjust to that reality, come to terms with it, understand what it means. And then, as I was saying with COVID, kind of figure out what that means for the new normal going forward, and make that the best new normal it can be. So let's talk about the specific commonly encountered symptoms and issues that we help with. This is kind of the list of things that we deal with most commonly, and I'm just going to take a second to go through each of them. So pain is, I think, on the list of things that people worry about most when they hear that they have cancer. It is probably one of the most common reasons that people with cancer wind up in an emergency department or wind up being in the hospital as inpatients. And it can make it much more difficult to stay on track with disease-directed cancer care. If you have terrible pain and it's hard to get out of the house or hard to, you know, get through a treatment, you might think twice and cancel a treatment or reschedule and delay a treatment. And so we know that having good control of pain helps people get their treatment as it's intended, as it's been demonstrated to be most helpful on schedule. The ways that we treat pain used to be very, very focused on the use of opioid pain medicine. So those are pain medicines that come from the opium poppy that are in the morphine family. So morphine, codeine, oxycodone, fentanyl, Percocet, Vicodin, those are probably names of medicines that you're familiar with. Dilaudid or hydromorphone is another one. And the role of opioids in treating cancer pain is shifting. That's for primarily the reason that people are doing better with so many of the newer cancer treatments that we have. And being on opioids for long periods of time when you're doing well and your cancer is stable and under good control with or without ongoing treatment during that time, we've come to realize that it has a different balance than we used to think. We used to think it was no problem, and we're coming to realize that there are a number of side effects of the opioids. And when people are going to be living with their underlying serious illness for a long time, they may do better with other kinds of pain treatment that aren't as focused on opioids. There has been a lot in the media about opioid misuse, opioid addiction, and the problems related to that. Those are not generally problems that come up for cancer patients. Cancer patients are not entirely immune to them, and so there is some overlap. We have some patients who are getting cancer treatment who have had problems with substance use disorder, or addiction, as people commonly call it, in the past. And we have to be extra mindful of how we take care of pain in those patients. But we want to make sure that we use opioids in a way that's safe and effective, and that we're not creating any new problems for patients during times that they need to be treated with opioids. Mostly we use opioids for very severe pain, and we use it for pain in an acute or short-term setting. So often after an operation, for example, or during a treatment that may be have a period of time during the treatment where pain may be a little bit more intense. Oftentimes towards the end of a course of radiation therapy, pain may be a little bit more significant before it starts getting better. And so patients may need opioids during those times. There are a small subset of patients who may need opioids over the long term, and we just do a lot of monitoring to make sure that patients are doing well and continuing to have good outcomes in terms of pain control and not having any problems or losing control over their ability to take the opioids safely. And we have a whole protocol within our department for what we do in terms of monitoring and assessing response to opioids. We use a lot of non-opioid medications, and as we've learned more and more, both about some of the downsides to opioids, as well as ways that some kinds of pain, particularly pain that's related to nerve damage, can respond better to medicines that are not opioids. And oftentimes we have to use multiple medications in different classes in order to treat pain most effectively. And then the other thing we do is we try and use things that are not medicines. Non-pharmacologic modalities. Those can be physical therapy. Those can be other physical modalities like electrical stimulation, heat, cold, massage, mindful approaches. So things like yoga and meditation. Some of those work by actually changing some of the brain chemistry and ways in which neurobiological signals are being transmitted in the brain. And some of those work by something sort of simple and intuitive like distraction. And oftentimes it doesn't matter how it works. What matters is that it does work, and it allows people to have better control of their pain and do the things that they enjoy and are important to them as they go through their day-to-day life. So we really try to take a very broad approach to that. And that also gets back to the question that was asked earlier about sort of integrative approaches. They're very much a part of things. Peripheral neuropathy is a very specific kind of pain that we see a lot because it is a side effect of certain chemotherapy treatments, and they happen to be chemotherapy medications that are very highly effective in the gynecologic cancer. So patients with gynecologic cancers are more likely to get these medicines, and as a result are one of the subgroups of cancer patients where we see peripheral neuropathy. Peripheral just means it's the nerves not in the brain and spinal cord, but in the outer parts of the body. And neuropathy means that it's a nerve that is not functioning in a normal way. My little picture that I got off the internet shows you one of the common manifestations, which is a feeling of pins and needles in the sole of the foot. People often also will notice it in their hands. And you heard Jillian tell you that I'm a knitter. Many of my patients who like to do crafts or are musicians will be more sensitive to this issue of peripheral neuropathy. And that can sometimes be a factor that makes the oncologist want to think about a different treatment if there are two treatments, one of which is likely to cause peripheral neuropathy and one is not. And the patient is a professional harpist, where that sensation in their fingertips is really crucial to their day-to-day function and their job. For most people, the symptoms are mild and they're able to get through it. Some people will notice it very transiently the day of or the day after chemotherapy. They notice it, but it goes away and it doesn't get in the way of their activities. Some people will have it get more intense as they get more treatment and more different kinds of treatment over time if they're in a situation where the cancer has recurred or is not responding as well as we hope to one treatment and they need to move to a different treatment. For many patients, once they're not getting treatment with these medications, the nerves slowly heal and the neuropathy goes away. There are a subset of patients in whom it persists. The best quality data shows a role for a medication called duloxetine. The common brand name for that medicine is Cymbalta. It originally came on the market and its original FDA approval was to treat depression and anxiety, but it now has FDA approval for treating pain. And is the medication with the strongest evidence base. There are other medicines that are used to treat neuropathic pain. Neuropathic pain can happen in many other medical conditions. Probably the one most people are familiar with is diabetes. And there are other medications which are commonly used to treat neuropathic pain in diabetes or other neurological conditions. And we do use those as well for peripheral neuropathy that comes from chemotherapy medicines. I get lots and lots of questions, as do my oncology colleagues, about CBD, which is one of the 2 active ingredients in medical cannabis or medical marijuana. The other major chemical is THC, or tetrahydrocannabinol. CBD can also derive from hemp, the plant that's used to make twine. And CBD is often available by itself. It's kind of, since the rules about importing hemp and CBD changed a few years ago, it's sort of in every health food store, in every corner of everywhere. There's very limited data about how much it helps peripheral neuropathy, either CBD itself from hemp or medical cannabis. A lot of the poor evidence base has to do with regulations at the federal level around our ability to do research on these substances. The bottom line is the evidence base is poor, and our evidence base around conventional FDA-approved medications is actually quite good. And so CBD and medical cannabis are not first-line medications for this, but do have a role sometimes when people aren't getting effective responses to other medications. And in the time, actually, since I gave this last talk, there's recreational cannabis in New York State. And so people who decide that they want to try that obviously should be having a conversation with their doctor, whether it has any risks for them given their specific both cancer and other medical conditions that they may have, but don't necessarily need to go through the process of getting medical certification for that, if that's something that they choose. Insomnia or issues with sleep are also really common. Those overlap significantly with other things that are going on. Sometimes pain affects our ability to sleep or sleep well. Sometimes medications we take can affect the sleep-wake cycle, and mood can affect sleep as well. Probably the most successful intervention for issues with poor sleep is what's called CBTI, or cognitive behavioral therapy for insomnia. And it's a very specific short-term psychological intervention that can be delivered by either a social worker that is a therapist or a psychologist. It doesn't involve any medication at all, and is really and has an emphasis on what we tell ourselves, kind of subconsciously, about our difficulties sleeping and behaviors that can help sort of shift the balance towards sleeping well, sleeping on a schedule that we want to, sleeping in a way that's effective and allows us to feel rested. One of the things that I think really came about a lot during the last few years, perhaps would have happened anyway, but I think we're really prompted by the stress a lot of us had during COVID, were guided relaxation and meditation apps or videos that are available through smartphones or on the computer. Many of them are available free of charge on YouTube, and others are either, ad-supported apps that you can get also free of charge on your phone or pay a small fee for. I can tell you that they gave healthcare providers access to some of them free of charge during the really early days of the pandemic when we were enormously stressed. And I marveled at how helpful they could be in helping us with sleep, and really recommend them highly. And you can, put some headphones in your ears if you share a bedroom with someone else and you want to make sure that this is not disturbing them. And they have guided relaxation. They have some prompted meditation. Sometimes they just have helpful soundtracks or noises that are relaxing. They even have these things called sleep stories, which are like bedtime stories for grown-ups. It's a story just with audio that is designed to be engaging enough to take your mind off of the things you might be worried about or experiencing in your body, but not so engaging that it activates you and keeps you awake, and is narrated by someone with a voice that will be relaxing and help you fall asleep. And they even have some of these things that are specifically designed for falling back to sleep if you've awoken during the night. With regard to things like computers and screens, there are certain frequencies of light referred to as blue light that come from our screens and can interfere with our sleep-wake cycle. And you can do things like put a sleep filter on many of your devices, or get a filtered lens on glasses, whether you wear prescription glasses or you just get non-prescription glasses with a blue light filter, to try and diminish that effect if that's something that you're sensitive to. We less and less use medications to help with sleep, especially on an ongoing basis, because the medications tend to be helpful if, you know, the night before you're going for a scan to find out the results of what your last several cycles of chemotherapy have done. You're really anxious and you have trouble sleeping, and you might want to take something just for that one night. Medications can be helpful. For people who have more chronic issues with poor sleep and difficulty falling asleep or staying asleep, medications tend to lose their effectiveness if they're taken on a regular basis. And some of the medications can result in people becoming dependent on them. So we really, really avoid those more and more. If there are some herbal preparations that some people find helpful, melatonin, which isn't an herbal preparation, but is a hormone that affects our sensitivity to light in our brain, can be helpful for sleep. And people often will have used that if they have issues with jet lag or shifting from daytime work to nighttime work if they work on a shift. But it's really important to make sure that your cancer care team and your other doctors know about any of those things that you want to try. Many of them seem to be safe, but some of them do have drug interactions. So it's really important to make sure that people know about any of those things that you're taking. And it also can be really important to be smart about caffeine intake. We don't feel that people need to stop having anything containing caffeine, but one needs to be thoughtful about when they take it and how much of it they take. So often, you know, you can have it, but early in the day, or if you need to reset your sleep-wake cycle and you're trying to make sure you stay up for a full day rather than napping in the afternoon. Fatigue is kind of the flip side to insomnia. Sometimes it is related to sleep. Sometimes it's not related to sleep, and it's really not sleepiness, but just a lack of energy to do activity and move. Sometimes that can be a manifestation of mood issues like depression, or people will often, you know, use the term kind of chemo brain that can manifest with some what we call psychomotor slowing and just less energy or less ability to move with the same quickness and alacrity that we usually did. Sometimes the ways to manage this, if it's a more short-term problem, is about managing our expectations and focusing limited energy on the highest priority activities. Light exercise and frequent bouts of short periods of activity are the most helpful. And there's also really nice data about yoga, low intensity yoga, as being helpful for improving energy. And again, you know, there are some resources, and I'm sure Jillian can share them with you, that we have through our centers. There's also a lot that's available online if you want to do those things, you know, at home, using something that's available online to guide you. There are not specific drug recommendations that we use in a very broad way, but we sometimes do use, again, strategically administered increased caffeine in your diet, or the stimulant medications that are used to treat either ADHD like methylphenidate, or sleep abnormalities, like a medicine called modafinil, to do that. Sometimes we'll use very short bursts of steroids. And you may notice if you get steroids before treatment or as part of your anti-nausea cocktail before treatment, that your sleep-wake cycle may be a little bit more disturbed after you got steroids as part of that. In terms of herbal or more natural approaches, American ginseng has been studied, but it's really important to know that's one of those herbal preparations that does have a specific drug interaction. Many cancer patients have a propensity to develop blood clots and are on anticoagulation or blood thinners, and American ginseng cannot be taken if you're on any kind of a blood thinner. Mood, depression, or anxiety are issues. You know, there are times when feeling sad or demoralized or worried is normal, and it shouldn't be medicated away, and it shouldn't be discounted. It's real and it's normal, and it needs to be acknowledged and processed. And, you know, I don't need to tell any of you that having cancer changes your life, and there is an enormous need for support. That said, there are also times when medication is appropriate because issues with mood interfere with our ability to enjoy life and function in all the ways that are important to you. And when issues with mood are intruding on our ability to enjoy life, and we can't sort of have those moments where we feel what we're feeling and then put them aside and do the things that we enjoy and are important to us in life, those are times when we often think about whether medication has a role by itself or in addition to talk therapies. In terms of anxiety, we try not to use the benzodiazepine class of medicines for anxiety. Those are medicines where dependence can develop and where the medicines can become less effective over time. They're also medicines that kind of hamstring us with regard to treating pain because they don't play nicely in the playground with many of our pain medicines, and they increase the risk of side effects and problems for patients. We have more and more effective medicines that don't have the drug interaction issues and are also helpful. Depression and anxiety can often kind of coexist, and many of the medications are helpful for both things. Venlafaxine is a particular antidepressant medication, which is also helpful for hot flashes, which depending on what kind of treatment or surgeries you may have had, and at what age you are when you have your cancer, that can be a significant symptom, and we can get sort of two symptoms taken care of with only one medicine. And duloxetine, the medicine I mentioned before, can be particularly helpful for neuropathy. And we usually use these medicines in the categories called SSRIs or SNRIs, which are the sort of newer line antidepressants. Weight changes can be a very big issue. There are lots of things that can affect appetite. Often they're medications, and it can be difficult to stimulate the appetite in ways that result in helpful weight gain. And by helpful weight gain, I mean lean muscle mass. It's not helpful to gain weight by holding on to water, and it's not helpful to gain weight by specifically increasing our fat stores. Weight gain can add to sleep issues and increase fatigue, affect our mood, and affect our self-image. So it's something that really is important to think about. Weight gain can also affect the risk of recurrence. So sometimes, even when we're not concerned about weight for some of these other issues, or we're not concerned about weight in terms of appearance, it may be something that we want to put a little bit of extra effort into managing and avoiding weight gain because of the way it impacts cancer recurrence risk or risk of developing other cancers. THC, which is the other medicine chemical I mentioned, that's one of the two major ingredients in cannabis, can stimulate the appetite. It's available in a pill that you can get from a pharmacy in isolation, in addition to being a component of cannabis, which is a really complicated pharmacologically plant that isn't, as refined and purified but THC also is the ingredient in cannabis that causes the most what we call psychomimetic side effects, which are the propensity for things like altered thinking, delusions, hallucinations, which are really quite undesirable. And so we have to be really thoughtful about using either dronabinol, which is the pill THC, or whether medical marijuana is something, medical cannabis is something that would be reasonable to try. Appearance changes. We can have differences in sensation depending on what kind of surgery you've had, around a scar, both externally, if you have, scars on the outside of your abdomen, or internally, if you've had surgery that's involved the vagina or rectum. We are also often super aware of every sensation that we have after we have cancer. We're often woulda, coulda, shoulda-ing about, did we pay close enough attention to the signs that led to our cancer diagnosis in the first place? And very super tuned in to any changes that we notice, because we want to make sure, if this is important, that we're not ignoring it and not neglecting to tell our medical care team about it. And that can sometimes make us stop trusting our own intuition about what's important and what's not important in terms of what we feel. Most of us, before cancer and before COVID, the first time we felt hot, didn't go check our temperature and didn't go run and do a COVID test, or didn't run to our doctor to get, checked for strep or flu. But our sensitivity to those sensations changes based on what we're experiencing. And, those examples I think are very universal in the last few years around viruses and infectious illnesses. And I think it's easy to see how that can apply to somebody who's had cancer. I'm going to touch just for a minute on sexual function issues.
I also just, Dr. Popp, I'm not sure if you are tight with time. It's 1 o'clock.
Yeah, I'm okay.
On our end, we can meet for as long as it works for you. I just want to be mindful for your schedule.
Thank you. I'm sorry that I'm running over a few
No,
minutes.
this is wonderful. I just want to make sure you know.
Questions. This is close to the end. Sexual issues are important whenever we think about anything gynecologic, and our bodies change, and there are changes in hormone levels, whether one's getting chemotherapy treatment as we age, and with some of the surgeries or radiation that are part of this treatment. And those sexual issues can certainly intersect with issues about mood and fatigue and pain in terms of our desires, our relationships with our partners, and all of those factors that are complex and part of sexuality. A specific issue that comes up for many gynecologic cancer patients is atrophy or thinning and weakening of the mucosa, which is the tissue that lines the vagina. People can find that there's a lot more dryness than there used to be. And intercourse, vaginal intercourse can become painful. There are simple things that can be helpful for some people, like personal lubricants. I know our colleagues in radiation oncology are very attentive to some of these issues, and will talk to patients about not only personal lubricants, but things they can do to make sure that elasticity and stretchiness in those tissues is maintained, using dilators to make sure that the tissue, as it heals and recovers from radiation treatments, remains as elastic as possible. Patient and their partner may need to explore different ways of expressing intimacy, love, and affection, either different physical ways or different ways that aren't physical. And some of these things very simply can be beyond the expertise of palliative care teams. It's not something that we all necessarily have treatment in. And depending on whether you're a palliative care doctor, what their nature is, what their age is, what their gender is, they may or may not be somebody who you're comfortable talking to about these issues. I think we're, again, really fortunate in our system that we have some special resources to deal with sexuality issues that come up for patients with cancer. And I know there's even been some new resources that have become available recently. And I'm going to leave to Jillian to talk about those because you know way more about them than I do. I'm just happy that these resources that are really important because our sexuality is a really important part of our relationships and our quality of life are available to patients and are not ignored. Much of this is a review. And some of this is what we talked about with the questions. So palliative care is based on need in terms of symptom intensity and impact of stress on you. It's not about prognosis. It's really about when these things are bothering you enough and the primary cancer care team is not able to address them in a way that's meeting all of your needs, then you pull in some more help and some more assistance. And it doesn't have anything to do with age or stage of disease or being at the end of life or whether this is expected to get better and if it's expected to get better over what time frame. It's really about what's happening now and how much help do I need coping with what's going on now. These are all the benefits that I think I've touted enough, so I'm not gonna go over them all in specific, but I think, you know, each of us just needs to think about which of these things are the things that are most important to us if we think that palliative care may be important to add to our team. I often get questions about insurance coverage and reimbursement. Palliative care is a medical subspecialty, so really the same things apply if you need to see a cardiologist or a GI specialist or an allergist. If it's covered by your insurance, it'll be covered to see a palliative care specialist. If you need a referral to see those people, you will need a referral to see a palliative care specialist. If you don't need a referral for those people, you won't need a referral for a palliative care specialist. Sometimes you have insurance that has network issues and sometimes you don't. Those things all apply. There are lots and lots of resources around the city in all the different healthcare systems and really in, I think, all of the networks in terms of insurance networks. And social workers are often the smartest people in the room, helping people find how to access those resources, given what their specific coverage issues are. There is more widely available coverage when someone's in the hospital than in the outpatient setting, but outpatient care is more and more available. Most of the outpatient care is office-based. It is still pretty difficult in much of New York City and the 5 boroughs or the metropolitan area to get care that comes to your home. But if you're feeling well enough and able to come to the office to see your oncologist and to get your treatment, often you're able to do that. Telehealth has exploded in the last few years, and telehealth for palliative care is often feasible and possible. I will tell you that just because of the nature of the medicines that we use, most of the time the initial visit needs to be an in-person visit. New York State doesn't allow us to prescribe any controlled substances for someone who we haven't evaluated in person in the office. And it can be really hard to keep track of that. We also often need to do a physical exam to help us understand the cause of the symptoms that are going on. Sometimes it's really obvious, and what the patient describes for us and what we can see from their oncologist notes or imaging studies is enough, but oftentimes we need a physical exam. So in our practices, both the embedded and the freestanding practices, every patient's initial visit has to be in person, and then if it medically makes sense, then we can do telehealth if that's much easier for the patients. And for now, telehealth is reimbursed the same way that an in-person visit is. Some of that's changing because the public health emergency from COVID is officially ending in, I think, 2 weeks. It's a specific date in May, the exact date I don't remember, but it's sometimes next month. And so there may be some changes about those issues in terms of regulations. But really, you know, the goal is to help you live as best and as long as possible. And that's by combining the best high quality disease specific cancer treatment with symptom management and support and doing it in as integrated a way as possible. And I think that's what most patients want, and that's what we want to help provide for our patients. Quickly, somebody asked about discussing this. We don't want people to feel like it's a hot potato issue and nobody's quite sure how to broach it, or as they're walking out the door, you say, oh, wait, by the way, what about palliative care? So if you're getting cancer treatment and you have symptoms or stress that's just getting in the way of doing what you need to do, and you feel like it's beyond what seems reasonable or is manageable for you with whatever your innate resources are for yourself and your family, then ask for a palliative care referral. That's really, a very general guideline, but it's very individualized. And say that you want it as the extra layer of support. In our system, we have such good relationships with our oncology colleagues that it's incredibly rare that an oncologist will say no. The oncologist needs to make the referral in our embedded practice. Patients can self-refer in our freestanding practices. Those kinds of rules vary from practice to practice if you're getting care elsewhere. I certainly think you can understand it would be impossible for me to keep up with how those kinds of issues are dealt with in all the different practices around the city, but it's certainly worth asking. I'm going to put in a plug for getpalliativecare.org. Which is the patient-facing website for the Center to Advance Palliative Care, which is a center that is based in our department at Mount Sinai and has really helped nationally and to a certain degree internationally the advancement of palliative care as a specialty and making sure services are accessible for patients and their families over the last 20 some years. Since palliative care became recognized as a subspecialty. And it has some specific guidance on how to help you figure out if it's something that would be of benefit to you. It's got some patient and family oriented podcasts and videos to help provide some support for people living with cancer and how they've utilized palliative care services. It's got a searchable provider directory and some handouts for patients and families, as well as guidance on how to talk to your providers. So a few minutes over time, but we're living longer than ever before in the presence of serious illnesses in our life, one of which is gynecologic cancers, and complex symptoms need to be addressed and are sometimes, but not always, addressed by the primary doctor managing those serious illnesses. Cancer and symptoms both can and should be treated simultaneously, and including palliative care in the overall treatment paradigm improves outcomes for patients living with serious illnesses, as well as for their loved ones. Patients and family members can and should ask for palliative care if they feel like they need it. And our social work colleagues and folks in your peer support network, like Women to Women, can help you with what their experiences have been in terms of ways to troubleshoot or to help with access if you're finding challenges. That's all I got.
Thank you.